We are excited to see all of you here. Let's see. We've got quite a few names, which is wonderful. This is great. Yeah, we've got a packed session today, but a lot of it is interactive. So hopefully we try to use the best time of your time that we can. Great. Eva, do you want to forward us along? Awesome. We'll keep them coming. We'll go ahead and pop over to the next slide here, but keep them coming. And I will actually hand it over to Eva, who's going to walk us through kind of the plan for today.
Thanks, Gabrielle. Hi, everyone. We just wanted to give you kind of an idea of our objectives for today's session. First, we will receive policy updates from the Department of Healthcare Services. We will hear from partnership today about process updates and additional resources. We will learn a little bit more about the new population of focus, which is children and youth. And then we will also continue brainstorming solutions along the provider journey. And so our agenda for today, we'll start with some housekeeping. We just went over the objectives. In a couple of the next slides, we'll provide some updates on our in-person event that we have upcoming. In part 2 of today's agenda, we'll discuss those policy updates, the process updates from partnership, and then do that overview of our new population of focus. In part 3, we'll have some breakout sessions where we'll talk about implementation, and we'll have 2 groups. We'll have an ECM provider group and a CS provider group. And then in part 4 of today, we'll circle back to the in-person session planning, what will come next, some additional resources, and then, as always, give thanks for all of our wonderful facilitators. Additionally, we have a copy of today's deck that will be put in the chat, so you can follow along and download that. But as always, we'll also follow up with all of today's session material. So we just wanted to kind of give everyone an idea of where we've been on this journey, the phase that we have remaining. So we are currently between phase 3 and 4 in this process. And in this new phase, we'll be focusing on monitoring, progress measuring, chronicling best practices, barrier busting, and then also making systems recommendations. So we wanted to touch base on kind of where we are in our in-person session planning. We're really excited about the opportunity to see everyone in person, share a meal together, and do some relationship building and capacity building together. And so we are really excited to share that actually Partnership has offered to host this in-person session at their office in Reading. The sort of time period where this would take place would be from 10 a.m. to 3 p.m. There are a few dates that you see listed here that are possible dates. And so we'll launch a poll in just a second to kind of get everyone's availability. We want to make sure that as many folks as possible can join. And then the goals of that day really are peer relationship building with Partnership, especially since we'll be in their office, and then training for capacity building. So right now I'm going to go ahead and launch that first poll. And if you could check off any of the dates that you would be available to attend an in-person session, that will give us an idea of the best day to schedule this.
And I apologize, I left in that 10 to 3, and that is my typo. Please reference the times that are on the poll. So the 18th would be 2 to 4, the 21st, 1 to 4, the 28th, 12. Those are kind of just blocks of time. We'll figure out from there. Yeah. But yes, we're very grateful to Partnership for offering to use their offices in Reading.
Okay, we'll give it another I don't know, 30 seconds or so if you have any last options you want to select. Okay, I'm going to go ahead and close it.
All right. Okay. Sorry, I might go ahead.
Okay. No, it's okay. And
I'm
we'll
excited.
also, yeah. I know. So thank you for answering that poll, and we'll follow up with additional details. Okay, so we're going to have another poll right now, which is also to just get more information about which topics you'd be interested in us focusing on for our in-person session. And with these topics, we have hiring and retention best practices, process improvement tools, kind of like the PDSA that we've been using, any CalAIM funding opportunities and best practices for applying, health plan coaching, free and effective e-platforms, and then anything else. So I'm going to go ahead and launch that. If, oh, 1 second. There we go. If you have any ideas that are not listed in this list, please put them in the chat and we'll be sure to track those, take note of that, and we'd love any feedback that you have. Okay, great. Give it a few more seconds. Thanks, Christina. Referral process efficiencies. Okay, I'm going to go ahead and close that poll. Great. All right, so I'm going to move on. We have another poll. We just want to get a sense of where everyone is in the PDSA cycle that we've been working on in this group, whether you're in the plan, do, study, act phases, if you've completed all the phases, or if you haven't yet started. We'd just love to get a sense of where everyone is in this process. All right, so that's been launched. Give it a few more seconds. Okay, and then I'll close this out and just. All right. And then we have one more poll just to get a kind of read again on where everyone is in this process. We would love to follow up on which area you've been working on in your PDSA, whether it's capacity building and workforce, care coordination, data sharing, workflows and processes, sustainability and infrastructure, community education, the contracting process, other, and then please use the chat if you have anything outside of that. And then NA, if you haven't started yet, you're not kind of sure which area you'd like to focus on. So I'm going to go ahead and launch this one. You could take a minute to. And then I'll close this out in a few seconds. If you can go ahead and put in any improvement areas that you've been focusing on. Okay. And I'll go ahead and close this out. All right. Thank you, everyone, for helping us gather that data, kind of see where we are moving into this next phase. And I'm going to pass it over to Gabrielle for the policy updates from DHCS.
Great. And thank you everyone for participating in those polls. It really helps us to get a sense of where folks are in their PDSA process, and also what's most valuable and what's most helpful to you as we create content for these sessions moving forward. So we can all take a big deep breath in, because we're about to start kind of a dense part of today. And I promise there is light at the end of the tunnel. So it's kind of dense. We're going to talk about DHCS updates. We then, our partners at Partnership are going to give you some updates on their process. And then we're going to talk a little bit about the new population of focus that came online in the beginning of July, or July 1st, which is children and youth. So all of that is kind of dense content. Then we'll be spending the rest of today in breakout sessions doing discussion and problem solving. So we just got to get through the content. Hopefully it's valuable and interesting, but just a heads up. So Eva, next slide, please. All right. So as probably most of you, if not all of you know, children, sorry, never mind. We're on DHCS policy updates. So on that same date, so in July, just about a week ago, DHCS issued updates to their policy guide, one for ECM and one for community supports. So this is what we're providing today is very high level summary of just some of the big bullet points from changes or updates that DHCS made. We are going to be issuing a much more in-depth summary of all of this for you in about a week or two. So stay tuned for that. We just didn't quite have the turnaround time between when DHCS released it and our session today, but we wanted to go ahead and give you somewhat of a preview. Also on each of these slides, you'll notice in that teal color at the bottom, you have a link to the full updated DHCS policy guide that was just released. And DHCS has actually done a really nice job of highlighting all the new stuff in red. And so it's pretty easy to go through, and it's dense and it's long, but it's easy to go through and see what are the changes. So that's also a resource that I would encourage you to look at. But just kind of high level. So one of the things that they clarified about member eligibility is that plans that we all need to be using the eligibility criteria that was set forth by DHCS, and that plans are not allowed to add additional eligibility criteria. So for example, for authorization. They also clarified that plans may not withhold authorization until a care plan has been completed, which may or may not have been the case in the Northeast. That was an issue in some parts of California. They also clarified in terms of authorizations that there's no annual reassessment that's required. The plans are required to have some way of, kind of doing oversight and tracking clinical progress. But the expectation is that plans are working with ECM providers to find ways to do that in a way that's not too burdensome for the ECM providers, but also gives the plans a good sense of where, what's going on with that person from a clinical standpoint, and tracking their progress. In terms of contracts, the big thing was that DHCS was specifying that they would really like for plans to largely be contracting with local community organizations that have expertise working with the populations of focus that they're contracted with. So they're, as opposed to contracting with, let's say, an organization that's not already familiar with the community, that doesn't already have a footprint there, or that's not already familiar with that type of member. Like, let's say they don't normally work with kids or something like that. That's not what they're looking for. So they want it to really be local, using that wisdom and that knowledge that's there locally that many of you are bringing to the table. They also clarified that for ease of reference, that on the provider directories of all of the health plans, that ECM and CS providers will be listed under other service providers so that they can be easily found, and you're not between health plans searching the provider directory to try to figure out where they are. In terms of member referrals, they clarified that the primary mechanism for identifying who might be a good, a member that might benefit from ECM or from community supports should be the community. So it really is those locally based community organizations that know folks the best. The idea is that most of the referrals for ECM and CS are coming from the community. That said, they also clarified that plans are also responsible for regularly and proactively identifying members who might meet criteria. So looking at, let's say, their ED utilization rates to identify folks that are going in and out of the ED a lot, or using the data that only the health plans have to identify folks who might meet eligibility criteria. It's kind of both and. They also have a really helpful chart on page 65 that talks about clarifies some of the kind of overlapping services. So what if someone is in this service, but they're also they also meet criteria for ECM? When is that duplicative versus when can that be complementary? I would really recommend that you take a look at that chart. And then finally, in terms of member assignment, so not all continuity of care rights apply to ECM services, but there are some continuity of care rights that do apply. So if a member has been receiving ECM in one county and they move to a different county, there's guidance on that. So definitely something to look at in more detail. And then the final thing was in terms of member assignment is that DHCS is really looking for plans to prioritize assignment to, particularly for ECM, to an organization or a provider that a member is already familiar with. So it may be that a member is not familiar with anyone, is not connected with anyone already, but to the extent that they are already connected with a local community provider, the preference for DHCS is that that we continue that we provide that continuity, that they continue to be able to see that or to receive services from that local provider as their ECM provider. So again, really high level, but gives you kind of a sense of what some of the updates were. Next slide, Eva. All right, and then the next two slides are just kind of, again, reference. So they clarified what types of providers or what types of organizations DHCS is thinking about or recommends to be ECM providers. So this slide is all about adults, population of focus. So for example, adults with serious mental health or substance use disorder needs. ECM providers might be county departments of behavioral health. They might be community-based behavioral health and medication-assisted treatment providers. For folks that are experiencing homelessness, maybe street medicine providers or homeless navigation centers. Now, this is not a restrictive list. So if you are a provider of ECM and contracted or wanting to be contracted for one of these populations of focus and you don't fall into these bullets, does not mean that you can't get a contract. It just, the DHCS is trying to clarify that these are the types of organizations that they are hoping that plans will contract with or they're recommending. And then if we go to the next slide, it's that same guidance, but for children and youth. So again, you see, more school-based clinics, public health, kind of existing CBOs that are already serving children and youth, things like that. All right, I think we can go to the next slide. And so that was all related to ECM. Then DHCS published a separate document, which you also have the link for for community supports. Again, there was a lot of overlap. So in terms of contracting, same thing, that DHCS, ideally is recommending that the health plans are contracting with organizations that already have experience in the community. Of course, particularly with community supports, this includes non-traditional providers, right, that aren't historically part of the healthcare system, which is sort of at the root of all of CalAIM. They also spoke to the piece about rate setting. So DHCS clarified that they have already determined that there is a good return on investment for community supports, or that they are cost effective in terms of the impact on healthcare costs. And so for the purposes of rate setting, that plans do not need to yes, and this slide deck will be sent out, not to worry. you will have access to this. That they don't need to assess community supports for around cost. Next slide. All right, and then again, these are just really high level. I know I'm moving through them quickly, but it's really just meant to give you a sense so that you can, we'll send you a much more detailed analysis in a couple of weeks, but this is just to kind of to get you going. So similarly to ECM, DHCS clarified that they expect the health plans to develop relationships needed to source the majority of referrals from the community. That the plans must consider referral requests from members and on behalf of members from their families, guardians, and caregivers. So that's really speaking to that issue of members being able to self-refer. That also includes having the health plan call centers and kind of those initial touch points at the health plan be well trained, so that if a member does self-identify, or if their guardian or someone in their family identifies that they might be a good candidate, that there's a set process for that. They also spoke to the need for certain authorizations to be expedited. We all know that there are certain situations where the standard authorization process would be too long, and so there's some clarification from DHCS around that. That included in that is anything related to recuperative care, short-term post-hospitalization housing, and meals being offered after acute care, that those are sort of inherently time sensitive. And then the other thing, and we're going to talk about this actually later in our brainstorming, is that the DHCS recommended or encouraged health plans to define a process for presumptive authorization. So this is where there would be a certain set of criteria by which the local organization, local providers could say, okay, if someone meets this criteria, we're going to go ahead and offer services, and we don't need to wait for authorization because we're on the same page with the health plan about what those criteria are. And as long as this person meets it, in certain situations particularly where there's a more urgent need, we can go ahead and provide that service and know that that authorization will be approved. So we're going to talk about that more later on. And then finally, in terms of claims, they were just these, reiterating kind of the standard Medi-Cal claims requirements around timely claims payment. Those timeliness requirements that are the standard Medi-Cal requirements, that those also apply for community supports and ECM. All right, next slide, Eva. Okay, let's see. And then there were also some things around the website, around eligibility, and around data sharing. And we won't go into all of those in details. Again, there's more to come. So we can go ahead to the next slide. All right. Okay, so here we have a little plug, because I know that was a lot of information, and after we hear from partnership, we're also going to hear about the children and youth populations of focus. So here's a resource. If you have any questions about any of this that you think we might be able to help with, please come to our office hours. They're Tuesday, August 1st and September 5th. If those times don't work for you, no problem. Eva and I are happy to meet with you one-on-one, and we've done plenty of one-on-ones with folks over the last several months. So please reach out to Eva and schedule some time with us. We would be happy to go through any of this in more detail with you. Next slide. All right, and I'm now going to pass it off to our wonderful partners at Partnership. And I actually don't know who all is going to present for us today. So I will pass it off to whoever from Partnership we have.
Hi there, everyone. This is Chloe Ungaro at Partnership.
Hi,
can you guys hear me okay?
Yes, we can. Thank you so much for being here.
Of course, and we have Bianca on the call as well. We are your program managers for the CS team and your ECM team. Go ahead and go to the next slide, please. Okay, so we have a quick agenda for you with some updates. We're going to touch on the billing and authorizations for ECM and community supports, data sharing on hospital visits, next steps as far as the DHCS policy updates that were just presented. We have a reminder for our PHC roundtables and then some links for some additional resources. Okay, so for ECM and community supports billing and authorizations, we did an analysis of the fourth quarter, and we determined that about only 10 of our 51 providers had submitted claims during that quarter. So we just want to remind everyone that if you have members who are enrolled in ECM and you are engaged with them, you're providing the services, please make sure that you bill for those services. We want to pay you. We are also finalizing some authorization and billing provider tools. This is expected to release in early August, but we will be keeping in communication with our providers, the CPIs, and any updates that we have on it, we will send out via our webpage and an email blast. Okay, so for the data sharing on hospital visits, as a reminder, Collective Medical has rebranded and they now go by Point Click Care. So we provide access to all of our ECM providers. This allows you to see real-time ER and inpatient stays. We are working on enhancing the platform to allow all ECM providers to see all ECM members in hopes to avoid duplication of multiple providers reaching out to the same member and trying to get them engaged. It looks like we have this all worked out and on the upload for August 1st. Fingers crossed, everything uploads and populates as it should. So we are working with Collective Medical. We've had weekly meetings with them to ensure that we're meeting that deadline. Next slide, please. Okay, and so if you have questions about ECM or if you have questions about community support and you're not sure where to go, reach out to the CalAIM at partnershiphp.org email. They can either route it, if you're not sure if it's an ECM question or a CS question, they can route it to the applicable teams. You can always reach out to myself or Bianca, who's on the call as well. We are happy to assist our providers. Right now, we are currently reviewing the updates that DHCS made to the policy guides. We are trying to implement any program or procedure changes that we need to, restructure on our end. And like I said before, as we have any updates or changes, we will ensure that we're communicating that with our providers. We have a link to our PHC roundtable and the community supports roundtables. The next one for, it looks like the last one, excuse me, for ECM was on the 20th last week, and then community supports was actually this morning. Next slide, please. Okay, and here we just wanted to give you guys a bunch of links so that you can have them readily available if you have questions, you want to deep dive, you want to know more than you already know. We have a bunch of great resources on our web pages as well. So if you have not already, please check those out. Right now, we are currently in the process of updating the recordings for the reporting trainings, so that way they match the new guidance and the updates on the templates that we've sent out to everyone. And I think that's the last slide. Yes.
Great. Thank you so much, Chloe. And we will, everyone, we will get out to you the dates for the next PhD roundtables. Apologies for that oversight. So, and I'm gonna do a plug for those. Definitely, we recommend going to those. It sounds like the emphasis is a lot more kind of the nitty-gritty, particularly if you have questions about process, or if there are components of process that are not working. Really encourage you to attend PhD's roundtables. So thank you so much, Chloe. All right, so last of our lecture form here is around the new population of focus that went live July 1st, which is children and youth. So we'll go next slide. All right, so again, down in the bottom in that teal color, you have the link for the detail for the policy guide with all the detail. But fundamentally, okay, thank you, Chloe. Fundamentally, there's information about who are eligible providers to serve children and youth for ECM services, and more importantly, who are the populations of focus in terms of children and youth that are eligible. So for providers, DHCS is looking for organizations that are community-based. Of course, we've talked about this, that have experience providing care to children and youth, that have experience providing culturally appropriate, intensive, in-person, and timely care management services, which many of you are already doing on the adult side. DHCS again clarified they do not set provider rates, so that's to be negotiated with partnership. That said, of course, DHCS does set rates with partnership in the sense that they pay partnership a certain amount, and then through a very convoluted process, but they do not set rates for how much the Medi-Cal plans can pay for their ECM and CS providers. And if you need more information on that, please, ping us one-on-one. We're happy to give you more. They also clarified that providers are able to submit claims either directly or to use, the DHCS has a form or a template for invoicing. So whichever one is easier for you, that there are options. And you do need to have a documentation system for care management. There's limited detail on what exactly that needs to look like, but you need to have some way of documenting. Then in terms of the youth, so generally speaking, this is up to age 21. The exception is that youth who are in foster care and who are involved in the child welfare system, they're up to age 26. So there's a little bit longer for them. But fundamentally, ECM is for youth who are experiencing homelessness, or who are at risk of avoidable hospitalizations or ED use, those experiencing serious mental health or substance use disorders, those youth transitioning from incarceration. If a child is already part of the California Children's Services or the CCS Whole Child model, CCS is going to be, their primary care management is going to be meeting most of their needs. But if they have additional needs beyond their CCS condition that could benefit from ECM or CS, then in that case, they can be eligible as well. Similarly, if a child has an intellectual or developmental disability, that does not make them eligible for ECM or CS unto itself. However, DHCS wants to emphasize the needs of those children. And so they're calling out that if a child meets another one of the eligibility criteria, like let's say they're unhoused, or they also have a serious mental health condition or something like that, then there are particular services for children with intellectual and developmental disabilities. And that's in part, they're calling that out because they want to ensure that health plans are contracting with local organizations that specialize in serving kids with IDD. Again, children involved in the child welfare system are also eligible up to age 26, and youth who are pregnant or postpartum. And go to the next slide, Eva. All right. So similarly, as we've been talking about, DHCS expects the plans to source most of the referrals from the community. That said, the plans are still responsible for doing proactive data analysis, to identify other, to identify referrals as well. Ideally, and this is where you talked about this earlier as well, ideally, someone is already serving that child, and that someone is encouraged to become the ECM provider. And this is really about, capitalizing on the relationship, or taking advantage of the relationship that that child and their family already have with that provider, and that the trust that likely already exists there, and trying to then broaden that. Similarly, outreach and engagement is known to be most successful when it's based on a pre-existing trusted relationship to a community provider. So DHCS is really putting a lot of emphasis on this. And we talked about the identification. Let's see, next slide, please. All right, so then they also, DHCS also clarified that ECM, and this hopefully is not a surprise, but is the ECM is designed to serve as a single point of accountability. So could they use this metaphor of like the air traffic controller? So they're not going to provide all the services, but the air traffic controller that's aware of what are all the ins and outs of this child or this youth's experience with various different community organizations, their PCP, their specialists, what's going on. And again, the person, organization, or entity that already knows the child best should ideally become the ECM provider. They also clarified that ECM does not take away funding from existing care management programs. And then they finally provided an example, and I tweaked it a little bit, but this is an example that was based originally on a youth, a boy named Gus, age 17, who was part of the Health Homes program and is now part of ECM. So he had been attending a drop-in youth center, and with kind of peer partners and getting a little bit of mental health support. But he had complex needs, and he also was dealing with a substance use disorder that at that time was untreated. So the youth center referred him to the health plan, saying, we think that he might benefit from ECM, and he was authorized to that youth center. So, they're the ones identifying him, and they're the ones that are then authorized to continue to provide services. Because that youth center was part of a clinic, the clinic ECM staff was then able to go to the drop-in center with him and just kind of casually meet the other folks that that he knew there that were involved with him, build rapport, and they were able to strategize a plan with him and his peer partners around kind of how to move forward. They then provided services to him at home and in school. And my understanding is that he's doing really well now. So DHCS highlighted this just as an example of what the vision is for this, right? It's really where people are, using the relationships that they've already built, and trying to get the richness of that and build off of that. Eva, next slide, please. All right, and then this I will let you look at in more detail on your own, but it's included in the guidance that that DHCS put out, and there's a checklist for the health plans as well as a checklist for prospective ECM providers who are interested in providing services to children and youth. So just kind of things to do to prep for that. All right, and now I think we have our another poll, which is, would you consider providing ECM services to children or youth, given that this population just went live? So yes, you are already doing that. You're ahead of the game. Maybe you're still considering it, or no, you wouldn't serve children because that's not a population that you serve, or you wouldn't because you are not providing ECM services. I'll give you a few minutes or not minutes, seconds, to fill that out. This will help give us a sense of who all's in the room as well. How are we looking, Eva?
We have about 50%, but that's not accounting for like our team.
Okay. Okay. All right. Oh, good. That's wonderful. 38% are already providing services, or all right. And then another 25% are still considering. So great. Wonderful. Thank you so much. Okay. And I think now we are going to move on to part 3 of today. So all of the lecture is over, and we now get to talk to one another, which is always my favorite part. So we're going to go into breakout groups. Eva, if you want to move to the next slide, please. All right. So what we're going to be doing today in our breakout groups is talking through some more of the pain points that you all identified through the provider journey. The first breakout group, and we can go to the next slide. The first breakout group is for ECM providers. The second breakout group is for CS providers. Some of you I've seen, yes, you're dual providers. We anticipated that. So for that, it's really a matter of what you'd rather talk about. In the ECM provider group, we're going to be talking about authorizations and kind of that idea of having pre-authorization for certain clients or certain providers. Whereas on the CS provider group, we're going to be talking more about claims payment and claims submission. So kind of where on the other thing we're going to talk about in the ECM provider group is around the quality of contact information coming from the health plans and what ideas we have for how to kind of stream or how to get better information to you on the ground for contact information for members. So ECM provider group is talking about things that are kind of earlier in the journey, and the CS provider group is talking about elements that are later in the journey around claims and things like that. So if you are dual, whichever one you'd rather talk about, that's where you can go. Also, if you are a pre-contracted or you are not yet contracted with the health plan to provide ECM or CS services, there's a link here that is a guide on contracting best practices. So definitely check that out if you're not yet contracted. You are welcome to come to either group for today, but also just know that that resource is available to you. All right. Well, I think it's all Eva from here on out. So I'll pass it over.
Thanks, Gabrielle. All right, thanks for those really insightful and informative conversations. We have one last poll for everyone. We just want to get a sense of which part of today's session was most valuable. And so I'm going to go ahead and launch that right now. Whether it was the DHCS policy update, the health plan spotlight from partnership, the information about the new population of focus, or the final section of brainstorming process solutions. And this is helpful just to get a sense of, what is most helpful for the group and making sure that we're incorporating that in future sessions. So I'll give it about 30 more seconds if you can just give us a sense of which part was the most valuable. And I will go ahead and close that. So it looks like the breakout rooms where we brainstormed process solutions was most valuable. So we'll definitely keep that in mind for future sessions. All right, so ahead of session 8, which will be our next session, we want to remind everyone to continue working on your PDSA. And if you haven't, consider the impact of your change in the study portion or move on to the ACT portion. And here are a few questions that you can ask to kind of help guide that process. Given the impacts we learned, what about this test of change do we want to roll into official policy or continue testing? Maybe you can think about what you would want to tweak and why, or maybe what would you want to eliminate by kind of working on your test of change. And related to that, as Gabrielle mentioned earlier, we are available for one-on-one support. So as you move forward in that process, please feel free to reach out to us to schedule a one-on-one or stop by office hours. We'd love to kind of help you think through this PDSA and how to move forward. You can email me in order to schedule those. And then if you are available to come to office hours, our next session is Tuesday, August 1st at 2 p.m. And then our September office hours will be on Tuesday, September 5th at 2 p.m. And the Zoom link is there. And as always, we just want to give a big thanks to all of our facilitators. We have our HealthBegins PATH-CPI project team. And then we have Gabrielle Alt-Riche, as well as the GASHAW group. So I want to thank everyone for collaborating and contributing to today's session. Thank you all for joining. There are resources at the end of this slide, and please feel free to reach out with any questions or to schedule a one-on-one. Gabrielle, do you have any last words?
Many of you in person, which would be such a joy. So Eva will be sending out some RSVPs soon with some more details. So please let us know if you're going to join us. We will try to have a remote capability to join as well, but we would love for you to meet the folks at Partnership in person, for you to meet one another, most importantly, and also for us for you to get to meet us as well. So hopefully we'll see you in person soon. Yeah, thank you, everyone. Have a wonderful afternoon.
I have one question.
Oh, yeah.
If I can ask. So I know that there are several different ones. Is there going to be multiple in-person CPI meetings in the future, or is this the one that everybody's going to be going to?
The plan was for this to be the one. That said, if it's tremendously successful and folks are really wanting to meet again, I think we could probably figure that out. At this point, we only have the one planned.
Okay, that sounds good. We are located in Sacramento, so we've been kind of going to the different various CPI meetings, but you guys are 3 hours away. The meeting's 3 hours away, but we are really going to be, we're really going to try to get there. So thank you guys for putting that on.
Thank you. Thank you so much. Well, hopefully we will get to meet you in person next week or next month. That would be lovely.
Take care.
All right.
Thanks,
Have a
everyone.
wonderful afternoon, everyone. Thank you.
Bye.
Bye, everyone.